Good afternoon, one and all. Every day is a chance to begin. Don't focus on failures of yesterday. Start today with positive thoughts and expectations. On this quote, Angela Rosario, on behalf of Sarvodaya College of Nursing and Sarvodaya School of Nursing, welcome you all for this webinar. As a part of the World Diabetes Day, which was observed on 14th of November, today we are here to acquire new information from this webinar on the role of healthy lifestyle in prevention and management of diabetes. I welcome everyone for joining us today for this webinar. As there is limited capacity on Zoom platform, I request the participants who are not able to join through Zoom can join us using the YouTube link shared. Please keep your audio on mute during the session. If you have any questions during the presentation, please type them into the chat box. I'll bring them up at the end of the presentation, and we will also have time for questions at the end. Now, without further ado, let's start. I call upon Ms. Chaitra, lecturer, Department of Community Health Nursing, Sarvodaya College of Nursing, to welcome the gathering. There's a chance to begin.
Hi everyone. I am happy to welcome you all to our 5th webinar from Sarvodaya College of Nursing. Good afternoon to all. I Chaitra K.R., lecturer from Department of Community Health Nursing, would like to welcome you all the webinar on the role of healthy lifestyle in prevention and management of diabetes. It gives me an immense pleasure to start this occasion by heartily welcoming everyone. It's my great pleasure to welcome Sir V. Narayanaswamy, Chairman, Sarvodaya Educational Trust, for this webinar. I take this opportunity to welcome Mr. Sunoj Matthew and Mr. George Thomas, Managing Directors, the Sarvodaya College and School of Nursing, for this occasion. I also welcome the eminent speaker and a guide, Dr. Ranjani Harish, Senior Scientist, Dr. Mohan's Diabetes Speciality Center, Chennai. A warm and hearty welcome to Dr. Dinesh Selvam, Principal, Sarvodaya College of Nursing, to this webinar. A warm welcome to Professor Jolly Joseph, Vice Principal, Sarvodaya College of Nursing, to this webinar. Now I would like to welcome all our faculty, Sarvodaya College of Nursing, to this webinar. I would like to extend special welcome to all the participants who have joined this webinar. Welcome you all. Thank you all.
Thank you, ma'am. Next, I would like to call upon our beloved principal, Dr. Dinesh Selvam, to address the gathering.
Good afternoon, everyone. Once again, on the another day for World Diabetes Day, we have gathered here for the seminar to highlight on the theme access to diabetes care, if not now, when. So with the wishes from the Sarvodaya group of nursing institutions, our chairman Sri V. Narayana Swami and our managing directors Mr. Sunoj and Mr. George, with their wishes and warm greetings, we go ahead with this particular webinar, which is being hosted on behalf of Department of Community Health Nursing of Sarvodaya Group of Nursing Institutions. The World Diabetes Day, which is celebrated every year on 14th November. And this year theme to access to diabetes care, if not now, when, where 100 years after the discovery of insulin, the IDF report says that even millions of people with diabetes around the world cannot access to the care what they need. So as nurses who have all been participating in this webinar, the nurses, the nursing students and the nursing faculty from the other institutions should have an input from this webinar, which is going to talk about the health lifestyle management, which is going to be rendered by a resource person, our Dr. Ranjani, who is a versatile and a very energetic person, being senior scientist at Madras Diabetes Research Foundation. We are very much fortunate to have a speech being delivered because her expertise in the field of diabetes is really going to help all the nurses who are attending this particular webinar, where they are going to enhance their care to the diabetes patients and the clients and the community, and all the recent updates which is going to be highlighted by our resource person of today will really going to help the nurses. So I focus where at the end of this webinar, the nurses are going to get enhanced in their nursing care and better outcome for the people with diabetes conditions, and they will be able to educate people with the diabetes and how they can promote advanced care to the people and motivate for a healthy lifestyle adaptation to prevent diabetes, which is one of the very key component of diabetes care based on the theme access to diabetes care. So with the greetings from Sarvodaya Group of Institutions, without taking more time, I once again welcome our resource person, Dr. Ranjani, and to deliver the talk for the today, which is going to benefit a lot of nurses. I can see the Zoom platform is already overloaded and it's going to be live streamed in the YouTube, where there are plenty number of students and faculty have joined. Over to you, Angela.
Thank you, sir. I take great pride in addressing our resource person, Dr. Ranjani Harish, PhD Certified Diabetes Educator. Ma'am is a senior scientist and head department of Translational Research, Madras, Diabetes Research Foundation, Chennai. Her research interest includes epidemiology, public health, translational and implementational science, with focus on obesity, diabetes, and CVD risk. She is the one selected and completed NIH Fogarty Fellowship from 350 global applicants at the Global Mobile Health Research Training Institute Fogarty International Center, Bestard, USA in 2016. Ma'am is a versatile person who plays an important role as an investigator in the field of diabetes and obesity prevention at school, home, and worksite settings. Current projects undertaken by ma'am are mobile health in prevention and management of NCDs, and interventions to improve PA and fitness in adolescent girls and women, and worksite-based intervention called India Works, being implemented across 10 work sites in India. Till now, I have said about current projects undertaken by MAM. I am delighted to talk about projects completed by MAM are Yoga and Health in Adults and Adolescents, Primary Prevention of Adult Diabetes, Prevalence and Incidence of Obesity, Diabetes in Children and Adolescents, Built Environment and Physical Activity. MAM has delivered about 90 inspirational and motivational lectures on various public platforms and has published more than 75 scientific articles, 6 book chapters, and several lay press articles. We are very honored to have one of the most inspirational person as a resource person for today's webinar. I welcome you, ma'am. Kindly please take over, ma'am.
Thank you, Angela, so much for that kind introduction. At the outset, let me first thank Dr. Dinesh Selvam, my ex-colleague. We worked closely at MDRF at Dr. Mohan previously, and it was very sweet of him to request me to come here for this presentation. It's my privilege to be presenting to so many nurses, because one of my main work at Madras Diabetes Research Foundation is to basically spread a lot of public health awareness and teach faculty or students on the various happenings or in research related to diabetes. So let me just jump straight to the presentation. Is this visible?
Yes, ma'am.
Visible, na? Just 1 second. Okay, so I think it's full screen also, right?
Yes, ma'am.
Yeah, okay. So let me go on straight to the topic that and the job I'm here to do. We'll address all questions in the end. Again, whoever's moderating, please let me know in the end, because I can't see the questions when I'm presenting. So what I'm going to be talking about is the role of basically healthy lifestyle in specifically diabetes prevention and management, but I'll start a bit from NCDs and then move on to diabetes, because I think it's important for us to understand what they are. So I'm representing my organization here, Dr. Mohan's Diabetes Specialty Center and Madras Diabetes Research Foundation. Dr. Mohan's Diabetes Specialty Center is the topmost ranked and the foremost largest tertiary care diabetes center in not just in India, actually the world, because we have the largest number of electronic medical records of patients over 6 lakh. And what is the speciality of Dr. Mohan's is, besides doing specifically diabetes care, we have a very strong research arm in Madras Diabetes Research Foundation, where we keep offering a lot of research data back, which is used in the clinic. And our boss, our mentor, our guru, Dr. Mohan, is a very keen and passionate researcher. So he's very, whatever comes in research, he's updated, and that's used in clinical practice. And I think that is the main. So by the end of this talk, it's not about just diabetes awareness. If I can kindle a bit research passion in many of you here, I think I will consider my job done. So let's go on. So let's start with little basics. Okay, so what is health? Everyone talks about health. We talk about physical ailment, right? We always know to talk about physical health. But let's remind ourselves the WHO definition of health, which is a state of mental, physical, and social well-being. And it's not merely the absence of a disease or infirmity, basically any absence of disease. So as long as people, don't fall ill, they always think they are healthy. But are they really healthy is the question we need to ask ourselves, as well as the person who's coming to us. Because many a times, and we know with Corona times now, a lot of the mental health has come back in the forefront, right? And even social well-being, because you are so homebound, you are not getting to meet people. So the real definition of health has actually come out well during this COVID times, because it's not just about getting COVID or being physically ill. It's a lot to do with the mental and social well-being of the person too. So what are non-communicable diseases then? So you have communicable disease, non-communicable diseases. Everyone is, so communicable diseases are something that spreads by touch, by different ways. It's an infectious disease. Whereas non-communicable disease does not really spread that way. But unfortunately, if you look at the global burden of diseases, NCDs are top ranked. So most people are dying due to non-communicable disease, and communicable diseases are more like, they're more epidemic, or they are focused on a specific area. They're endemic. They might be specific to Africa, specific to India, things like that. But NCDs is a global phenomenon. It's happening everywhere. It's even worse. I think after Corona, we should start calling NCDs a pandemic more than an epidemic, because it's there all over the globe, and it's happening in all parts of the world, whether you're rich or poor. It's affecting everybody. And what is the main thing about NCDs and why the focus is on that is because they're all lifestyle driven, right? There is a genetic predisposition. I will be speaking a bit about that too, but it's 80% to 70% lifestyle driven, and lifestyle is in whose hands? It's in our hands, right? So that is the reason it becomes very, very important to understand what NCDs are and the risk factors around NCDs, because more or less, if we can take care of these risk factors and the kind of prevention you do for one NCD, it is applicable to all the NCDs. And that is why I'm putting them under one gamut, so that though I'm going to be speaking specifically on diabetes, eventually it will basically takes care of many of the other NCDs. So what are the NCDs? Cardiovascular disease, top ranked. Of course, then there's diabetes, there's cancer, there's COPD, which is basically asthma, chronic respiratory diseases, injuries, mental health, hypertension, obesity, dyslipidemia. All of these are basically coming under NCDs. Why I have highlighted this year? Because just last week, the International Diabetes Federation released, we call it an atlas, released the latest figures for diabetes. And globally, currently, we have 537 million people who are suffering from diabetes. So what are these risk factors? Remember, I told them they all can be for, the risk factors are common for all NCDs. So though we're focusing on diabetes, remember, these are common risk factors. So if you take care of them, for even one, you're taking care of them and preventing other diseases too. That is why the gamut of NCDs or non-communicable diseases becomes important. So high blood pressure, which is hypertension, physical inactivity. I will be speaking a lot more in detail about physical inactivity later. Obesity, obviously, if you're not eating well and if you're not doing activity, it's understood slowly our weight is going to increase. Raised blood cholesterol, decreased fruit and vegetable intake. Very, very common. Everyone thinks India is largely vegetarian and hence people are eating a lot of vegetables and fruits. Believe me, it's a myth, because we don't really eat a lot of vegetable and fruit. If we do, what is the most common vegetable that if you commonly go and do a random survey in the street anywhere across India, north, south, east, west, if you ask what is the most common vegetable people are eating, it will be potato. And what's the most common fruit people are eating? It will be banana. Both are high starch, right? Banana still has a few micronutrients like magnesium and things like that, but potato is nothing but starch. So we need to change that, and we do have a lot of variety of vegetables available, especially we're lucky in India, and we should be using them. Raised blood glucose, which is what I'll be focusing on next. Of course, alcohol and tobacco use. So alcohol, just like it's in moderation, but tobacco is an absolute no-no. There is no point of saying restrict tobacco, it doesn't work. And tobacco, please remember, it includes, people generally talk only about smoking, but there is something called smokeless tobacco. Your pan parag, supari, all that comes under gudka, they all come under smokeless tobacco. And that is also as bad as smoking. So now let's get the focus to diabetes, okay? Let's look at the increasing prevalence of diabetes. Now, when we started our research studies way back in 2000, so I'm showing you the increasing trend here, right? So in 2000, it was around 31.7 million people with diabetes. But as the years and the progression increases, just see how it is systematically increasing. As I said, this was 2011, it was 62.4, and currently 2021, exactly a decade later, it is 74 million. And the prediction for 2030 is that it is going to cross 100 million, definitely, no matter what we do. So What we are trying to focus here is this. So remember, out of this 101 million, 40% is preventable. So if we talk about the actions that I'm going to be speaking about today, if we as healthcare professionals do something about it, diabetes can be absolutely prevented. And if not prevented, what we try to say is it can be delayed in people. Because what has happened is for years before, people, we used to have diabetes was something which came over age and things like that, right? But right now it's coming at a much younger age, which I'll be talking about later. But what happens due to that is the complications also set in very early. Hence, if we cannot, when we say prevention is not in the pure sense. Remember, we're talking more about delaying the disease so that instead of getting at the age of 30 and 40, let's get it at 60, 70. But if you sustain your prevention, you might be actually absolutely able to prevent it all your life, right? So that is the main thing about prevention. I'm sorry, because I'm a co-host, I guess I keep getting that thing about admitting people. So I have to keep clicking that back. Otherwise the slides won't be viewed. So why this high susceptibility to type 2 diabetes in Asian Indians? It's a very common question, because before I move to lifestyle fully, yes, there is a little genetic predisposition, and we need to, I think, because the audience was nurses, I thought I'll keep it a little technical initially, and then of course we'll talk about lifestyle in detail, which is more lay terms. So what is it? Why are Indians more prone to type 2 diabetes and CAT? So what is this genetic predisposition we keep talking about? What it's called is the South Asian Indian phenotype. Okay, so when we have a South Asian Indian phenotype, what do we mean by that? We talk about greater ethnic susceptibility, means lower age of onset of type 2 diabetes, lower threshold for BMI for diabetes. So, it's no longer that you have to be very obese to get diabetes. Even at lower thresholds, even at 25, 26, 24, just around that borderline, 25 and 26 of BMI also, we are susceptible to diabetes if we have a family, very strong family history of diabetes. We don't need to get very, very obese to get diabetes. So that's the point. Because another thing is, in Caucasians, typically diabetes will come at the age of 50 plus. But with our latest studies, we are seeing type 2 diabetes happening very commonly in the young. Right from the age of 20, we have started to see type 2 diabetes. And whatever I'm speaking about today, let me again warn you, I'm not addressing type 1 diabetes. All this I'm talking about is basically the 90% of garden variety diabetes we call, basically that is type 2 diabetes. That's the most common diabetes that we see. But there is something called type 1 diabetes, which is common in children. And that's a very different type of diabetes. It doesn't happen due to lifestyle. It doesn't happen due to family history. It cannot be reversed. So please understand very clearly, type 1 diabetes is much more serious than type 2 diabetes, because a person with type 1 diabetes has to be on insulin all their life. Today, what we're talking is mainly when you talk about prevention, it's mainly about type 2 diabetes. So the other part of the Asian Indian phenotype is increased insulin levels. So what we call as insulin resistance. But what we are seeing with time is also decreased insulin secretion. That is also seen to be a problem among the Asian Indians, due to which we have very typical dyslipidemia characteristic. And this is something you should note also when you see your patients, if you're interested in studying for diabetes, is in a South Asian phenotype, typically we have low HDL. And remember, HDL is the good cholesterol. We'll have low HDL, due to which automatically HDL-LDL ratio changes. LDL becomes higher. When sugars are high, triglycerides will also be high. Overall, total cholesterol also becomes high. Then, of course, there is low level of adiponectin. That's another kind of a secretive hormone, which we will talk about. It's basically an inflammatory marker, and it's seen very commonly in Asian Indian phenotype. Increased abdominal obesity and visceral fat. I'll be speaking about this later, but please remember, in the typical Asian Indian phenotype, more than BMI, what is more visible in us is visceral adiposity, and that is one of the highest risk factor for CAD, that is for cardiovascular diseases. So we all have tummies. So if you see overall, we might even be thin. Even the thinnest of person will have some tummy. So where is our fat coming mainly? First on your stomach, on your tummy, then the hips, then the arms, and then the legs. So arms, legs, and all with different kind of exercise it goes. But it's very difficult. We all know, especially if you're a woman, you know it more. It's very difficult to remove the fat which is built around your tummy. That takes much more specific exercise, much more workout and strict diet control. As I said, inflammatory markers are high. CRP was one of the markers which even became high during COVID. So it has taken a lot of cognizance nowadays for people to understand. But yes, in a South Asian phenotype, inflammatory markers are also high. And another thing very commonly, a lot of work being done, it's called the Barker's hypothesis, is low birth weight, which is the thin fat Indian. And that's, I think, something very important to remember because we associate it a lot with obesity. Of course, the epidemic is driven by overweight and obesity. But remember, just because a person is thin, they will have a lot of visceral adiposity still. And those people are at equal, if not at high risk of diabetes. So as I said, age and sex specific prevalence of diabetes, see the takeoffs. Okay, it starts literally at 20 to 24 is what this is from our ICMR India study, which is one of the largest epidemiological studies being done in India currently for diabetes. And this takeoff is so early. Whereas if you look at this and add it, I'm not showing the other side with Caucasian, you compare it with Caucasian, their takeoff comes, I think I should show this. Sorry, their takeoff will be somewhere here, right? You can see my laser point, I think. And so their takeoff typically comes in this area, whereas our takeoff is here. So it's very important to understand that imagine if your diabetes starts so young, complications typically in a person with uncontrolled blood sugars will start within 5 years, the microvascular complication. So imagine your own productive life, you're already gone into complication of diabetes and things like that. So it's very, very important to understand that it's important to prevent, and if not, at least delay the process so that these complications come at during a productive age group should come a much later, where it's still manageable because we are still, we don't have the stress of working and things like that. So it can still be taken care of. So this was one of the papers we published on how it's similar as the diabetes with Pima Indians and Asian Indians. So Pima Indians are very typical. It's an ancestral, we trace kind of the same trajectory, but of course they were American Indians. So if you look at the comparison, it was understood since we have a similar trajectory, we should have very similar kind of BMI and things, and that's why we are at high. Because initially, everyone, it was curious, why are Asian Indians so high risk for diabetes before the South Asian phenotype actually came about properly? And we started looking at, and we kept saying, oh, we have the same trajectory, and hence like Pima Indians, we are also at high risk. But if you see the prevalence of diabetes, yes, it's high in both. But the Pima Indians are very obese. They should have a BMI of about 30 always, so 33, 34 on an average. Whereas we are relatively thinner, as I said, because of the South Asian phenotype, and a BMI of 25. Around 25 to 28 is good enough risk to get diabetes. Higher mean 2R plasma glucose is what the Pima Indians used to have. Whereas we, in our studies, are very clearly seeing people having higher fasting plasma glucose than 2R plasma glucose. Pre-diabetes, again, most of the Caucasians and Pima Indians started with Pima Indian prevention studies. You go to UK, you go to US, Australia, it's always isolated IGT, which is more. Whereas in our own prevention studies that I have also conducted myself, we see a higher amount of isolated IFG. Okay, so IFG is impaired fasting glucose, and this is impaired glucose tolerance. So IFG is basically your fasting values are higher, whereas your 2R values are higher. And most important, it was always assumed, and even now, of course, we have a very large share of insulin resistance happening among Indians, but it's seen off late with the work we have been doing, it is also a problem of insulin secretion. We, as a South Asian phenotype, again, the Asian Indian phenotype, we seem to be secreting lesser insulin, and as the weight increases, as the load increases, the pressure on the pancreas to secrete that insulin is lowering, due to which obesity has that slight role to play. So how much is preventable? So I'm having spoken about the Asian phenotypes, I've given a genetic base. Now let's talk about what's preventable and how we can manage it with lifestyle. Again, one of the studies that we did, we looked at something called PAR, so population attributable risk factors. That is, we list all the factors from our epidemiological studies and found out that obviously 5 risk factors, which is obesity, physical inactivity, unfavorable diet score, which means nothing but unhealthy eating, hypertriglyceridemia, and low HDL, as I said, contributed to almost 81% of incident diabetes. 81% of incident diabetes is in 81% of actual new cases of diabetes. But leave all the others. Just look at 2 risk factors, unfavorable diet risk score and physical inactivity. This explains 50% of the new cases. So you know very well where you have to attack, right? If you want to prevent or delay diabetes or even manage it for a person who has diabetes, all you need to attack is this. If these two things are taken care of, it's absolutely preventable and manageable. This is mainly a disorder, and hence lifestyle plays a very important role. So where are we going wrong? So this is a picture of the Madras famine, okay, in 18th century, long time back. I'm not saying we need to go like this. Obviously, that's also a sign of malnourishment. But see from there where we have come, right? So there is this transition that has happened over the decades is very quick for any kind of a civilization. And from here, when we reach here, this is what we have reached at. Because due to the epidemiological transition, we've had urbanization, globalization, westernization, all this has reached to this. And with this, what we have done is invited all the different kinds of diseases to us. So Dr. Mohan had put a very nice term for this, and that's called affluenza. So just like you have influenza, one of the forms of strains of COVID is basically, and with affluence, and that is when you have a lot of money. Diabetes is one of the first foremost diseases that come in. Funnily, a few years back, even just I would say a decade back, diabetes was a sign of rich. So people would not hide; they would actually be happy they got diabetes because it's a sign of prosperity. It's a sign that you have money, you've been eating unhealthy, and due to which you've got diabetes. You don't have time to exercise. So now from there, slowly people have realized, look, it's not something that we should be very proud of. So that is why we call it affluenza, because it's a sign of affluence when you have increased caloric intake, decreased physical activity, and urbanization, which means you've moved to vehicles, you're not walking, even the normal walks that you did is not happening. Now let us move to certain terminologies which we use very casually. We need to understand what are the cutoffs, because many a times I see most colleges, a lot of people still using cutoffs which are basically done for Caucasians, that is done for Americans, people, in Europeans and things like that. They're not applicable for Indians. Right now, we have done enough research in India that we have every cutoff which is specific for India. So let's follow those and not follow what the Westerners are following. So generalized obesity, the body mass index for South Asians, it is overweight, that is your BMI. If it's greater than equal to 23, you're already overweight. And if it's obesity, if it's greater than equal to 25. Whereas if you go to the Americans, it will be 25 overweight and 30 obesity. And why this cutoff came? Specific because of the Asian Indian phenotype. We realized we are at risk. Remember, I told you we're at risk even at lower BMIs, due to which we had to move these cutoffs. Researchers came up that the cutoffs have to be lower. Otherwise, we are waiting for someone to become 30. They have already full-fledged diabetes and having all kinds of complications. That is why we had to reduce this numbers. Abdominal obesity. As I said, it is not just overall BMI. Please remember to look at waist circumference. Very, very important. Very imagine. Nobody needs to tell you you have a tummy, right? You look at yourself in the mirror, you know you have a tummy. So please understand what is the cutoff for weights for men above 90 centimeters, for women above 80, which is basically 36 inches pant size and 32 inches pant size for women. So of course, from 32 to 34, you don't have to worry, but you're basically telling you that, oh look, your pant size is increasing. Overall, we might, even our weighing scale might not tell us. It might just be a marginal increase for weighing scale. But as your inches increases, you have to start realizing, oh, okay, we need to start reducing weight. Similarly, when you're doing a weight loss program, don't focus just on BMI. People are always obsessed about their weight. Be obsessed about your waist circumference, about your arm circumference, about inch losses. Focus on inch losses. They're smaller targets and they're more easily available, more easily achievable with if you're doing a good healthy eating pattern and physical activity. So simple things, right? So when to emphasize, I think they say a picture speaks 1,000 words. In 1990, we had these big fat TVs, Mota TVs, but we were all thin. But now we have all flat screens, and what we have is the Mota paunch here, right? We're all become this way. So this is what is globalization, westernization, everything that you call. These are the transitions when we say this is what we are talking about. Why again abdominal obesity is important with risk to diabetes? If you see our research again, we say, Dr. Mohan always says, longer the belt, shorter the lifespan, simply because just as your waist circumference from 70 centimeters, by the time it becomes 80 centimeters, see how the prevalence of diabetes is increasing from 11 to 31. That's not a small number at all. So please understand, as the waist size increases, our risk for all kinds of NCDs, starting with diabetes, also increases. So what is diabetes? I know mostly they are nursing students here, and if there's lay public, everyone knows about diabetes. But rather than going, I would rather stick to the simple definition of diabetes and saying lack of insulin is not secreted. please understand basic definition of diabetes is hyperglycemia, right? There is blood sugar. There is should the sugar or the glucose be in the blood? No, it's supposed to be in the cells. What is the hormone which puts that blood glucose, basically the glucose from the blood into the cell? It's insulin. So obviously if insulin is not working, the food that you eat is getting converted to glucose and it's lying in the blood. So your insulin has to work so that it takes that glucose that is roaming in the blood and puts it into the cell. And a little bit of physics, what is basically when you convert that glucose into energy, and energy is nothing but the capacity to do some work, right? So it converts to energy and then it's stored in different places, right? In your muscle, it will be stored in some other cells and it is used as and when needed. But if that main hormone is not functioning, then the whole rhythm goes for a toss and then the sugar is happily floating in the blood, and that's how it starts attacking. It becomes toxic, it becomes inflammatory, and it starts attacking a lot of other cells in your body. That's what leads to complications. So one of the biggest risk factors for not allowing that glucose to go into the cell is obesity. Because obesity, then what it does, it covers the insulin from acting. So you remove this obesity as a layer, then insulin functions also better. Very important on normal blood sugar values. I know as nurses, I think you'll also know better. Every lab will give some different standards. Please stick to ADA standards, American Diabetes Association standards. Fasting blood sugar is 70 to 100 milligrams per deciliter. Postprandial, that is 1.5 hours after breakfast, should be between 100 and 140 milligrams per deciliter. So anyone who gets, say now from 100 and 140 after 1.5 hours, so 70 to 100 has to be fasting. Another important thing is understand what is fasting. A lot of people will come in the morning at 10 o'clock, 11 o'clock and say, take my fasting. I think we should not, be very strict about asking when their dinner time was, that they're really fasting. If they've had only water, it's fine. But if they, after you take their sugars many a time, they will say, oh, I actually had just a cup of coffee. So when you're giving instructions to patients to come for testing, also be very clear about the term fasting. Don't assume they know what fasting is. Many a times patients think it's okay to have a cup of coffee and come, or come late and come at 10 and 11. Do not take samples. You will get wrong readings. Preferably sharp by 8 or so, wrap up your fasting samples. Similarly, the timing for postprandial also is important. Based on this, the diagnostic criteria for diabetes, again, I'm just highlighting this because a lot of people use as per their convenience, or different labs use different standards. So fasting, as I said, 170 to 100 is normal. So obviously if it's 100 to 125, it is the condition called pre-diabetes. If it is greater than or equal to 126, then it is diabetes. Then if you are taking at a 2-hour blood sample, then 140 to 199 is pre-diabetes, because remember what the normal is, 100 to 140. So 130, so 140 and above is basically pre-diabetes, and over 200 is frank diabetes. Random blood glucose, where you are not fasting, you've just walked into a clinic, somebody wants to just take the blood glucose, you can take it. And the way to interpret it, of course, it has to be followed up with the oral glucose tolerance test or a fasting test. But even in a random, you kind of get an idea of a person which stage they are in. So if it's a greater than 120 to basically 120 to 200, we call it pre-diabetes, even in random blood sugar. And greater than 200, so if somebody comes with 400, blood sugars and random, they have definitely frank diabetes, irrespective of what they've eaten. But if they're in this borderline and random, what happens if somebody says it's 202? High chances it might be less. It could be just based on what they've eaten. So you have to follow it up with the fasting. Then comes the most important one, which is glycosylated hemoglobin test, HbA1c. Many labs, many doctors do not recommend it still, because sometimes they don't do it in their hospital. But please understand, this can be done in the non-fasting state. And hence, it's very, very important that we do this so that it gives you a 3 months average, right? So the 3 months glycosylated hemoglobin test, sorry, it went back. Yeah. So the 3 months glycosylated hemoglobin test, the pre-diabetes range is 5.7 to 6.4. Whereas greater than 6.4%, that is 6.5 and above, is basically diabetes. Okay, this gives you a 3 months average. It's basically your glucose value sticking to the hemoglobin, and we know the hemoglobin has a 120-day lifespan, so 3 months. So every 3 to 4 months, looking at your glycosylated hemoglobin is very, very important, and gives a very good indicator of what how the sugars are behaving, because it's not driven by what you just ate in the previous meal, which is common when you're doing a fasting or a postprandial. Symptoms of diabetes, sudden weight loss, excessive urination, itching in private parts. Please remember why I'm putting this up is because in 50% of individuals with type 2 diabetes, they do not show any symptom. That doesn't mean they don't have it. It's that they don't realize these are symptoms of diabetes and you have to go and show a doctor maybe to it. Very commonly is recurrent UTI, urinary tract infections. And people don't realize if it's coming recurrently, maybe there could be a sugar thrush. So you have to go and check also for blood sugars. So these are very common symptoms. You have to think about it and then go. Many a times they just come for a corporate checkup and get ruled out and then their sugars come 300 and they themselves are shocked saying, oh, I was totally fine and had no problem. So please understand 50% of people who come with diabetes don't actually have any symptoms. Now, why do you worry about diabetes? You worry because of the complications. Nobody really dies of diabetes, right? They die of the complications. So as I said, microvascular retinopathy affects the retina of the eye, nephropathy affects the kidney, and neuropathy affecting your nerves. These complications are known to come in between 3 to 5 years of uncontrolled blood glucose. If you're after a person gets diabetes, if they're managing their blood glucose well, you need not get this so early. This themselves can be delayed by 15, 20 years. There are people who are living for 30 years without complications also, only because they do regular follow-up. They go to their doctor regularly, they do their tests regularly, and they're very disciplined in their lifestyle. Otherwise, it's, these start setting in very, very early. Similarly, macrovascular is affecting your coronary artery diseases, and PVD is basically goes to stage of gangrene and leading to even amputations of an extremity of any of your fingers or your toes and things like that. And as I said, we have done research on complications also. It's not a small number. There's a very, very high number of people having these complications. So if you want to do prevention, that is where you do it. So you can do it at every stage. Levels of prevention, mainly I wanted to highlight this, is people think only diabetes means prevented. Once you get diabetes, you can't do anything about it. Not at all. Remember, it's a disorder. So at every stage, you can prevent diabetes. Before you get diabetes, obviously, when you're at high risk, say you found out you have pre-diabetes, please check your lifestyle immediately. Start doing the things that you need to do, and you'll be able to prevent the onset of diabetes or at least delay it. Secondary prevention is people who have had diabetes. You prevent yourself from getting the complications. And the people who have got, say, some kind of little bit of kidney changes, early complication, move. Tertiary prevention is when you try to prevent end-stage complication. A person need not end up with kidney failure just because a few, microalbuminuria has gone high or low. There are very good medications for diabetes. As I said, it's a very important screening. That's why when the theme for World Diabetes Day is also access to diabetes care, it is also about the first step about access to diabetes care is what? Is regular screening and regular follow-up. Right? If you have regular screening and you follow up with your doctor regularly, you are going to have good access to diabetes care. But if you're going to go to a doctor every month in 4 years, 3 years, saying, doctor gave me one prescription, I'm following it, it doesn't work because diabetes is one of the most researched, most of the non-communicable disease. So you have a lot of new medication, a lot of new technologies coming in every passing day. So please be sure that even in your family members, whoever you know and whoever's listening in, if you have diabetes, regular follow-up, regular testing, very, very important. Changing those medicines, checking that they're on order. Sometimes they go high, sometimes they go low. So you need to be in touch with your physician to know what is happening with your body, right? So 5 ways to prevent, it's a lot of common sense. I don't think everyone knows about a healthy diet, increase physical activity, maintaining ideal body weight, stress reduction, and screening at regular intervals. I think it's the fifth one which people don't do. Other four, everyone is more or less aware about. It's just that we don't do anything about it. And that's why discipline is one of the biggest driving factors if you want to make any changes in lifestyle. So going on to the diet, everyone's pet topic, food consumption. Why there is so much noise about carbohydrates? Because what has happened in India is, unfortunately, our diet is very much carbohydrate driven. We don't do anything. That's how it's been. In you go north, south, east, west of India, you take a plate. What is first taken? Rice or roti or chapati, whatever you take. But that's what you will fill in your plate first. The sabzi, everything else will come much lesser. Then if there is a sweet, you will go and include that a lot, right? That is something we will include. But carbohydrate and fat is what drives our main kind of food. So unfortunately, in carbohydrates, over time, what has happened is refined cereals, which has led the fact. I will come to that again on why that is a problem. We also did a survey of processed foods in Chennai market, and we can't blame you or us as consumers, because what the market also gives us is Basically 80% of starch and sugary foods. All we are getting is this. We are getting maximum amount of starch and sugary foods in the market. You go, you're pushed, bombarded with this. So what will a person buy then? You have only around a 5%. Even now, the health market, the healthy food market or organic market, and all is still a very small percentage. And 15% is things like frozen foods and things. So anything that comes out of a packet is going to be high in salt, high in fat, and high in sugar. They might add a sweetener instead of a sugar. So it may become low in sweet or in sugar, but it'll still be high in salt because you need to have preservatives. Anything that's in a packet needs a preservative, and a preservative typically will be something sweet or something salty. So please bear that in mind. Most important, again, when you're looking at these foods is be sure that you read labels. People have now started looking at expiry dates, but please be sure that pay attention to reading labels, reading to ingredient lists. All that is very, very important. When you buy a diabetic bread, be sure that when it says a diabetic bread, it has to be only whole wheat flour or whole grain. It cannot have whole wheat grain, and the second ingredient in that typical brown bread or whole wheat flour bread is maida, and then it is sugar. So if you don't read the ingredient, you just look at outside packaging and say, oh, diabetic bread, my father has diabetes, I'll buy that. Look at the ingredients, you'll understand where you're going wrong. As I said, vegetable intake. India has a rainbow colors of vegetables and fruits. Unfortunately, we do not consume them. So our traditional meal pattern, think of it, how your forefathers were eating. You don't need to go eat in a banana leaf, but you please include all these vegetables. They were there then also, they're there now also. Every city, every state has very specific vegetables that are grown, which is, there are seasonal vegetables are grown, seasonal fruits. Use them. What is seasonal? Use them. As I said, make in India, made in India. These are stuff. Another thing is be local, be vocal about being local, right? So what is grown locally? Use those foods. That is what is meant. That's what you're meant to eat. Don't go searching for foods which are from other countries, from other states. When what you have in your state, just have those, and they all come well in season. They're not, pesticides and all that is later. If it's a local, it's a seasonal thing, it will grow well. But when you go and buy something, you want to go and have a mango in December, obviously it's going to be a problem because they are preserving it for you. Mango, that's not the season. So if you eat local and you eat seasonal, you're eating the right type of vegetable and fruit. Include these kind of rainbow colors. This photo is taken from Coimbatore market in Chennai. It's not some photo collage we have done. So these are vegetables available in, if you go to a proper vegetable market, go there and see that you include different colors in your diet. Why are they important? Simply because it's very straight. This is what WHO recommends is 5 servings of fruits and vegetables. 5 servings means just consider it as 5 batis. Just take 5 cups, 5 batis of vegetables and fruits together. So say 3 vegetables or 4 servings of vegetables and 1 fruit a day, even if anything. Or even one day you miss a fruit, at least 4 times a week if you're having a fruit also is great. And remember, when I talk fruit, I'm not even including banana in my list. I'm talking about all the other apple, mango, apple, oranges, mosambi, pears, chiku, all those different ones which are available per season. So the 5 servings, just look at rural and urban. You would think rural people eat more. It's not at all. In urban, we are having around 12.2% people who are eating those 5 servings. And in rural, it's only 6.3%. Because their starchy foods are more prominent because maybe they're working higher. They're so used to from times to you eat a lot of starchy foods, right? So there's a lot of rice, and whether it's parboiled rice, put rice, whatever it is, but they eat more of those kind of things. Vegetables is still a small quantity, and sometimes they eat, a lot of people who are non-vegetarian eat more of the mass and more of meat and things like that. But vegetable consumption in India, unfortunately, for a so-called agricultural country, is very, very less, and we really need to improve that if we want to build our immunity and improve our prevention. Simple things. Remember, I told about how visceral adiposity causes a high risk for diabetes. So if the more vegetable you eat, the lesser is your waist size. The lesser vegetable you eat, higher is your waist size. Similarly, your LDL cholesterol, higher vegetable, lower vegetable. See the values on there, right? So it's an inverse proportion. So please make it important, that make it a habit that you increase and include amount of vegetables and fruits in your diet. Now, what is HFSS foods? High fat, salt, sugar foods. Very, very important in today's times. As I spoke about packaged foods, we have a fetish for white. Everything that is white we think is good because we associate white with quality, but that's not really the case. Salt, milk, sugar, maida, chiroti rava, all these are whites, which you should actually restrict in your diet. I would say as much as possible, avoid maida, avoid chiroti rava. Have lapsi, have dalia. They are little more higher in fiber. They will be, the GI will be lesser. But rice and all that, don't have the refined rice. Try to go back and find a rice which is more rich in fiber, the kuth rice or the parboiled, the hand pound rice as we call it. In Kerala, the red matta rice. But what has happened in every rice, people have tried to polish it, and why we are polishing it is because consumers are asking us. Initially, remember atta, that is the wheat flour. We used to go get it from a chakki. Now what you do, you just buy any of the packets that are available. So go and find a chakki. There's a chakki still available. Those wheat flours mills which are still available locally. You go buy wheat gram and give them. It will be a little coarser flour. Means your fiber content is still intact in your diet. So please ensure you can do. Of course, millets is a huge thing nowadays. Include a lot of oats. Include bajra, jawar, barley. All this include in your diet. Yet oats, people buy from the packet and make it. If your oats quick, the brand is Quaker, I know, but they call it quick cooking oats. If your oats cooks, anything that cooks quickly is basically doesn't have fiber in it. You need to understand that. Anything that takes more time to chew has high in fiber. And what you want is a high fiber food, because that's what gives satiety to your stomach. That's what will delay gastric emptying, and that's what will help you to control, have portion size and control your meal. So even if a little bit of, you have a fruit, automatically it will delay. You'll not feel hungry immediately because of the fiber. Same thing, the fruit, if you have a fruit juice, one fruit is around 50 to 60 calories. You have a fruit juice, you will take 3 to 4 fruits. So your calorie content also increase. And what happens in the fruit juice? All the narichattu, that is all your fiber, is basically thrown away, right? And what you're drinking is nothing but sugar water. So we encourage this a lot in our children. So as parents, as teachers, please be aware. Don't encourage these sweetened juices, malted drinks in your children. Okay? Once in a while is okay, but it should not be a daily thing. Bakery products, confectionaries, all of them are rich in trans fat, which is what dalda, vanaspati, margarine. No having too much of trans fats, they also cause a lot of cardiovascular risk, right? Sugars are known by different names: corn syrup, glucose, honey. Again, as I said, you need to understand food labels, read labels to be sure what you are really consuming. Just a small terminology of glycemic index, where it's a carbohydrate property of food. As I said, it's basically the ability of the food to increase your blood sugar levels. That's all it is. So the range for glycemic index is anything higher than 70 is it's as good as having glucose. Anything in the range of 55 to that number is basically around 69 is kind of medium GI, which is where most of our products fall, okay, including rice will fall here only. That is, I'm not talking about refined rice and all come here, okay? But anything which is a little more high in fiber comes here. Very rare to get less than 55 GI products. They have to be really good health products for that. White rice intake and diabetes risk. I've already said why the big noise about white rice. Just look at a simple thing. So your first quartile, your reference range is 200 grams of rice, okay? Normal white rice, which is around one big wati, not the small thing, one big katori, you can say. That's your reference range. Now, from there, your odds, as you keep increasing from 2 cups, from 1 cup when you go to 4 cups, okay, you see the amount, how your odds of diabetes has increased. It's become 4 times more from 200 when you become 400 grams of white rice. So please understand the risk that is accompanying with this. So what are the simple dietary tips? Continue with the traditional meal pattern, not too much of a headache. People think we tend to mull over all the wrong things. Can I have ghee? Can I not have ghee? Having a little ghee on your roti, putting little in the rice with the dal doesn't cause anything. But people bother about ghee, but will be happily having fried fish and deep frying things and eating. That's more of an issue. Mainly cut down on refined carbohydrates, most important. Use more coarser cereals. Use a lot of vegetables and fruits, sprouts in your diet, and all your pulses as much as you can. High protein for vegetarian is nothing but dals and pulses. Sprout them. They improve your multivitamin, multiminerals also in your diet. Avoid, basically, I wouldn't say, we never say avoid, just restrict the fried foods and sweets. Use different types of oils. You don't have to go and buy and cook in olive oil just because somebody's telling you from a Western country. Use your traditional oils. But remember how much to use them. Even our usual diets, different foods, different kind of items you make, we make in different oils. That is enough. Just follow the traditional pattern. Of course, decrease consumption of bakery products and mainly increase fiber. Millets, I just put a small slide here because a lot of people nowadays are interested in millets. These are the different types of millets. What it is doing over rice and wheat, if you see, the carbohydrate content is more or less similar. They're not giving you lesser carbs, but they're giving you a much higher fiber content. And many times they're giving you much higher protein also in most of the millets. So again, millets also nowadays in the form of, there are frauds everywhere. So please see that you're not having refined millets and see that you're having millets which are healthy, which are unrefined. Because the main thing of millets is fiber. If your millets get refined, even this fiber that is giving will go off. So jawar, bajra, nachni, ragi, whatever you're having, the different kinds of millets that you have, I put it up here. Please start including them as a substitute for rice and wheat. I'm not saying remove them, but use them as a substitute. Very important is to change the way you eat. I think this one slide is one of my favorite slides on how much you can fill in a plate. Nowadays, your first behavior change is take a smaller plate. Don't have a big, people have big thalis. Don't, because then you tend to fill it. So take a normal, make a smaller plate, fill half of your plate with vegetables. Here it's fully cooked. I would say take quarter of, a small portion of raw and then another portion of cooked. So 2 vatis of vegetables and 1 small vati of raw salad. Now, when you say salad, again, people go exotic. Just simple, cut a few cucumbers or a tomato and some onions or whichever, radish, whichever you like, but ensure that you have raw salad always every day as part of your meal. 1/4 is whole grain, whether it's roti, rice, whatever. 1/4 is pulse dal or meat or whatever you're having. Ensure you have at least 2 liters. Okay, 2 liters is minimum. And what do you do that for that? Is make a bottle of water, whether it's a steel, copper bottle, whatever you want to use, but ensure that you have a bottle dedicated for yourself and you are finishing 2 liters of water a day. I think a lot of us we tend to forget to have water, and that's where again the problem starts. I think it's important to understand why that healthy eating pyramid is important. See, nowadays we are all ulta like this because our tip is wrong, right? We are all with refined foods. If you reverse this pyramid, what is the base of the pyramid? It is the regular exercise. Get regular exercise in and reverse this pyramid, then your base is clear, it is strong, and will be more healthy. Unfortunately, we are all in this inverted pyramid nowadays. Coming to physical activity, we are all big fat couch potatoes, and thanks to Corona, we become even more fatter couch potatoes. Role of exercise is tremendous. There's decreased blood sugar, decreases cholesterol, increases your HDL. It works better than even statins for increasing your HDL, So nothing like exercise to remove the bad cholesterol out. Decreases blood pressure. We know it's a stress reliever. Decreases insulin resistance, and of course prevents complications. And more importantly, it helps you maintain your fitness. So what are the recommendations for exercise? It's 150 minutes per week of moderate to moderate intensity aerobic physical activity. How do we measure MVPA? It's around 5 to 6 kilometers you should be able to cover in an hour. A lot of people say, I go walking. Walking for how long? For 25, 40 minutes you have to walk. How much you have to walk? 2 kilometers, 3 kilometers. That's not walking. That's just rambling. That's just generally having a talk with your friend. If you're doing it from an exercise perspective, please ensure you're at least covering 5 to 6 kilometers an hour. Start with a warm-up, wear good shoes, wear comfortable clothes, and see that you don't get injured while doing it. In the absence of this, walking is the basic. You can do cycling, running, whatever you like. Play a sport, but ensure you do it for an hour. Weight training is another important aspect that we should include as we grow older. 25, 30 plus, start including weight training. It's not specific for men, even for women. It is not about, for men, yes, they will build better muscles, but for women also, converting that fat into a bit of muscle. We don't become muscular, but it's very important to make stronger bones for flexibility, for stronger muscles. It becomes very, very important as we grow older to include weight training in your part of your exercise routine. So why is it important? Because Indians basically are a very lazy nation. Okay, we see, if you look at this graph again from India, what we have found out is only around 10% of Indians, actually 10 to 12% of Indians, do any kind of recreational activity. Recreational activities in your free time, instead of reading book, watching TV, yapping with friends on the phone, or staring at your phone. what you are doing is basically looking and doing some kind of exercise. That is, working out during that free time is what is recreational activity. How many are doing? Only 10 to 12% of Indians. So with that, we did our biggest prevention trial, and it's one of the topmost prevention trials from India called DCLIP. And we found almost where we called people to our center. If you see this, we called people to our center and we taught them to exercise. We taught them about lifestyle change as lesson plans. And we found a 32% reduction in the incidence of diabetes. So we actually managed to prevent diabetes in these people by doing a clear-cut lifestyle change program. However, there are barriers to lifestyle change, and I really want to highlight, this is the last few bits of my presentation, is everyone understands the benefits of exercise. So if you see exercisers, also 90% and above say, yes, I know it is beneficial, it helps me, all blah, 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 all those kind of things. But nobody's doing it, right? But the barriers are much more in women than in men. I think that is very, very important to note, because we are a male-dominated society, and the tendency for when you say access to any kind of healthcare and diabetes care, the focus is always on men as a breadwinner. Please understand the women also need that much more help when accessing any kind of healthcare, and from there, the barriers they face is also much more. So when you talk about exercise, how many of the women really do go out and exercise? Obviously, we found they were much lesser. And their barriers are much, much more, because they take out of family time, about the clothes you wear, because of socio-cultural context, people looking at us, you're always conscious, then it tires them out. So if you're working and doing housework, they don't want to go into exercise, which tires them out, then they have to come back and again cook. So there are a lot of more barriers in women then, and similarly for girls, compared to boys. So we actually came out with an ideal intervention for specific for women and girls, which was innovative, because these were the barriers that people faced. And we thought it's important that we address all these barriers and come out with a specific intervention for women and girls, and that's Standard, where we combine what do Indians love to do? We love to dance, Indian women especially, right? And even overall, we love to dance. You play a music, whichever language it is, if people tend to move about a bit, and it's happy, it's stress-free. So we thought we should make dance as an exercise routine, and we combined with something called high-intensity interval training, and we are specifically rolling it out now for adolescent girls and soon for women. A small bit on stress reduction, where we will say it's a mind-body connect. So yoga is the in thing. A lot of people are doing it. But again, I would say whether it is a diet that you're consulting, an exercise program you're consulting, or yoga you're consulting, please follow a qualified person who's doing this, who knows about this, and not some social media influencer or some YouTube video or some quack, because it will cause you more harm than good. Do not follow fat diets, and do not follow somebody who says, oh, I lost 15 kgs, now I can give you a diet. They are not the people who should be giving you diets. We have qualified people who can give you that. Approach the right people. Similarly, learn about it properly before you recommend it to somebody. Yoga also, it is fantastic to include yoga as part of any kind of exercise routine. There are a lot of people who do yoga itself as form of exercise, because it also has the flexibility portions, and they have stretches and postures also taken care of. So please learn it and then do it. And it's, again, in Corona times, deep breathing, pranayama has come out in a huge, huge way. So it's very, very important, even 5 minutes of pranayama to just relieve the stress, when you start of your day and end of your day, I think goes a long, long way in not just management, but prevention of disease, and also overall getting a calmness in yourself, in your body. So I would just like to end with how early screening for diabetes and NCDs is very much necessary if you have a family history of diabetes, high waist circumference, and or increased weight. So as I said, NCDs can be absolutely prevented by lifestyle modification. Be smart about your food choices. As a nutritionist myself, I would say just moderate. Moderation no longer is for alcohol, it's for food, it's for physical activity. And here I have to point out, a lot of young, fit people have died, right? We have Kanra stars, we've had a lot of stars, and from all the film industries who we know have been fit, who have passed away after a bout of exercise. And this has given excuse to people who don't exercise, saying, look, if you exercise, this is what happens. Please understand that's not the case. There have been a lot of interplay of factors. So overdoing anything is wrong, even if it's exercise. So please do not overdo anything. Moderate in your food choices and your exercise, but regular physical activity is an absolute must. You have to remove 45 minutes at least. Start with 20 minutes to 30 minutes a day, then move on to 1 hour, and ensure you're doing something for your physical activity. Remember, fatness nor thinness, both does not equal to fitness. So try to maintain somewhere in the normal. You don't have to be very fat, you don't have to be very thin, but maintain somewhere. And as long as you're able to maintain your fitness, I think that's the key. And how do you maintain fitness? Walk up a few stairs, you will know how fit you are. So our mantra from Dr. Mohan is always eat less and walk more. Thank you. I'm sorry for all the noise because our clinic is at a junction in Bangalore. There's always a lot of noise here. Can I stop sharing, Dr. Dinesh? You're muted.
Yes, ma'am, sure.
Can I stop sharing? Okay, thanks.
Thank you, ma'am, for sharing your valuable information regarding the important role our lifestyle plays for keeping us healthy. As we all know, we are in a fast-forward era. We are very lucky to be enriched with a lot of information from your presentation. Once again, thank you, ma'am.
You're welcome.
We will go ahead and take some time for questions now. Just a reminder, please be sure to type your questions into the question box in your control panel. Okay, it looks like we have a few questions.
Yeah. Do you want me to read it or you're going to?
Yeah, I'll read it for you, ma'am. The first question is, people below the age of 35 years are at risk of what type of diabetes?
Good question. There are risks of all types of diabetes, type 1, type 2, and gestational. And nowadays, you also have a big gamut of OD and things like that. So type 2, as I said, is very clear cut. If you have a family history of diabetes, you're overweight a bit, and you have other symptoms, it's more clear that it will be type 2. Type 1 generally is an autoimmune disorder. So it happens suddenly. It can happen because of infection, most commonly due to even a fever and a flu, it can happen. Your body reacts to a kind of an outside infection, and then the pancreas get affected and suddenly insulin stops getting secreted. That I think maximum we have seen type 1 happening till the age of 32 till 30 years in our clinic. But we can do genetic tests and also rule out that there's no other type of MODY, which is basically some kind of genetic variation in this kind of type 1 diabetes. But as I said, type 2 diabetes is also now beginning in the young. And of course, if you're a woman and you're married and if you're overweight, there's something called gestational diabetes that is also happening, where a person gets, the woman gets diabetes during her pregnancy.
Ma'am, the next question is, does the people with the diabetes necessary to meet endocrinologist?
So I wouldn't specify endocrinologists unless they have other complications of the endocrine, but there are many diabetologists because you have specific courses now in diabetes, which we also do, fellowship in diabetes and things. So they would say fellowship in diabetology. They would have been done a specialization specifically for diabetes, and they would be the people you should be consulting. Of course, their first format will always be general physicians because general medicine covers diabetes, comes under that. But there are people who go one step further after that and get more specialization in diabetes. So what happens with them is it's a little more because they're focusing only on one disease. They have more of the know-how and the thing that happens for diabetes. That's all.
Okay, ma'am. The next question is, what are the good travel foods for people with type 2 diabetes?
Travel foods, avoid the package. Just cook food from home and put in a dabba, and that's your travel food. That's all. So it's a roti, sabzi, whatever you find, like, whatever we used to do traditionally when we used to go by train. Of course, now you go by plane, so we don't take all that. But in train, what we used to take? We used to make one chutney or, a roti and carry some homemade chivda and things like that. Nowadays, as I said, we are bombarded so much. And of course, people come in the train, they offer you food. There are things local. In fact, that's also an adventure, right? So when you're traveling from one state to another state, you will have local people coming and selling fruits and things like that, which is what you can buy. But instead, we'll go buy the chips and fill a bag with that and eat only that and ignore all that, which is also a socio-cultural learning experience. and you also understand about the foods of different states. So yeah, that's I think would be the best. Best is to pack some food, especially if you are a person with diabetes. It's good to carry some food with you from home.
Nice, ma'am. The next question is, can menopause affect glucose levels?
Very much it can, because it affects stress, it affects your hormones. You can do stress eating, and stress eating typically is related to high HFSS foods, which is high fat, salt, sugar foods, because that's what calms your nerves at that point of time. So menopause definitely will affect glucose levels.
Ma'am, some of the questions are, what is diabetes reversal?
Good question. So what is diabetes reversal is, firstly, the term reversal is misunderstood. It's not reversal, it's remission. So there's something called, just like in cancer, a person who's had cancer, after 5-6 years, you would say the person is in remission because they haven't got it back, but you might get it back anytime, right? But at that point of time, no cell of their body is affected by cancer. So that's what is remission. Similarly, in diabetes also, a person after our lifestyle intervention program, there were a lot of people who went back to normal glucose values. And when they go back to normal glucose values, when you say reversal, they should not come back again. But that's not the case. If they leave that disciplined lifestyle and some kind of issues, they will always come back to diabetes again. So there's always a chance of coming back, and that's why it's called remission. It's absolutely possible. It's happening in a lot of people with good medication, with good lifestyle. Bariatric surgery in very obese people causes this. But as you know, if you're not particular about your discipline after that, with terms of lifestyle, even after bariatric surgery, you can put on weight. So these are the things we have to bear in mind.
Do all obese people develop diabetes?
No, not at all. Just like not everyone who eats sweet gets diabetes. So that these are myths that people say. Everyone who has a sweet tooth then should be having diabetes. So diabetes is not at all related to how much of sweets you eat. It's more related to overall lifestyle more than anything else.
Okay, ma'am, this is a part of our nursing. So as a community health nurse, is there any tool to assess the risk for diabetes in population?
Yeah, we do. And I think Dr. Dinesh can also give that to you. It's called IDRS. It's called Indian Diabetes Risk Score. It's a very easily available tool. It has 2 modifiable risk factors and 2 non-modifiable risk factors. So when you look at modifiable risk factors, you're looking at physical activity, and when you're looking at waist circumference. So both are related to, how you can change it, and you change your risk. And the other 2 are family. Non-modifiable risk factors are age and family history. You can't change to the family you're born to. So that's how it is. So that's a very simple scoring pattern, and you can use that to detect risk. When even to study, a lot of studies, we use that to determine risk in a community.
Ma'am, the next question is, how much blood sugar levels will affect the kidney and its symptoms?
So the threshold for kidney is generally 180. So anything above 180 will start affecting your kidney. So on a daily basis, if you're going to bombard your kidney with above 180 blood glucose, it is going to start getting affected slowly and steadily. You're weakening those cells in your, the capillaries in the kidneys. But overall, I guess it's just a good control. So, initially your dipsticks used to all be 180. The cut point used to be for ketone bodies and all that. But now, of course, you don't need blood sugars. We don't use that many. But it's good. So that's why overall, a person with diabetes, what we recommend is your daytime value should be below 200. Not fasting, daytime. Over the day, if every time you're always below 200 and below 180, even more better, because then you're really under good control. That will also reflect to an HbA1c of less than 7 typically, or at the most it will be between 6.5 and 7.5, which means good control.
Okay, ma'am. Does Ayurveda medicine have any effect in reducing the blood glucose level?
I don't know, because I don't do Ayurvedic research and there aren't much papers, but there are foods that are rich in anti-glycemic properties, simply like methi, then there is karela, there is bitter gourd. There is work done on it, and it is shown. There is Garcinia, there is aloe vera. There are a lot of things that people are working on, which is shown to reduce the blood sugar. But we take it with a caution, because there are no toxicity studies done with this. And we all know most of the products, if they're toxic, what they're going to affect first is your kidneys. So yes, they do have anti-glycemic properties, that's known, and they're known they can reduce your blood sugar levels, but of course in tangent with everything else. You have to take care of your diet, your exercise, your medication, all that together. This is a bit of, having an aloe vera juice in the morning, or having your Karela juice in the morning, jamun. These are all things that people have. It's okay to have, but please be aware that it affects your liver and kidney, so don't overdo it. That's all. You can't drink a glass of aloe vera and then go gobble sweets and do everything and expect your diabetes to go away. It's not happening.
There's an interesting question here. Does actively exercising but having high stress level leads to diabetes?
What stress level?
High stress level.
See, if you're exercising out of stress, it should relieve your stress. If exercise is causing you stress, then you're doing the wrong exercise. Okay, so anyone who runs any kind of, whether you're doing yoga, you're doing rocking, running, you're playing a sport, you do that so that it helps you relieve your stress. So you have to figure out your timing. You have to figure out what are those stress triggers, and maybe take that time out and go get your exercise routine at that point of time. But there is something called stress-induced diabetes, which is temporary, which is transient, and it can go back to normal sugar level. So, there are periods of stress for people, right? So something maybe doesn't have a job, or there is some family issue happening. So there are sometimes periods where people get diabetes just at that period because of high stress, and they're not able to do anything about it. But once they realize the problem, they realize the trigger, and they take care of it, the sugars are known to go back to normal also.
Ma'am, the next question is, apart from glucose test or HbA1c, any other tests are to be carried out for a diabetes patient?
So if you're ruling out diabetes, typically we do an oral glucose tolerance test. I think most of us don't know that. OGTT is what you give a person if a person has come to rule out diabetes, which is you give 75 grams take a fasting, give 75 grams of glucose, and then take either the 1 hour, 2 hour, 3 sample, or you do 2 samples. And then based on that, because what you're trying to see is the glucose, how the glucose load affects your pancreas, and when the insulin is secreted normally, then your whole thing has to be dissipated. The blood glucose should move out the sugar should move out from the blood and move into your cells within the 2 hours. If insulin is not functioning properly, then it will take more time, which will get reflected in your blood values. So besides OGTT, I think this is what you would do. We do a normal fasting PP for a person who has diabetes, and glycosylated hemoglobin initially used to be done only for people with diabetes, but nowadays we do it even for the newly diagnosed and in research and everything, because we find that a much better indicator simply because it's the 3-month average. And sometimes in pregnant women, there's something called fructosamine that you do, but that's not common for others.
Last question is, what can we do in order to get maximum effectiveness of medication?
Discipline, that's all. So we have studies where in research we do, the more number of lifestyle measures you're able to implement in your life, the number of medications come down. It is proven. We are showing it more with more and more interventions, whether it's yoga, whether it's any kind of exercise, any kind of healthy eating. The more you get a disciplined lifestyle, automatically your medications come down. The more indisciplined you are with your lifestyle, we will have more medications, we'll have insulin, everything coming. Then no point blaming the doctor or anybody else that they're giving so many medicines.
Thank you, ma'am. That's the end of all the questions. Thank you for answering all of our questions.
I just want to add one thing, where Dr. Mohan's Diabetes Specialities Center also offers some course for nurses. If Dr. Ranjani permit, I may tell about that course.
Please do, sir.
Yeah, that is about
You're leading it, so you should be telling.
Yeah, it is in collaboration with Dietary University, where we have Diabetes Nurse Educator course, where all the nurse can know more about diabetes, and they can learn about self-monitoring of glucose and patient education and insulin administration. And this will be helpful for all the nurses to establish themselves in the diabetes, taking care of the diabetes. It's very, very very feasible course where you people can go and attend only on one Saturday. And there are around 4 modules. It is module-based course, and you are going to get the certificate in collaboration with Dr. Mohan's Diabetes Education Academy and Deakin University. And many of the nurses who have received the certificates are successfully working in that specialized area. So I think nurses can consider this opportunity, and they can they can go to the website of Dr. Mohan's Diabetes Education Academy and can mail and find out the more details about the course, and more students who are in the final year who are going to complete their course can just think about opting this course for your career benefit. Thank you, Dr. Ranjani. It was a wonderful talk. And the nurses, really, all the students and the staffs would have benefited out of this, the latest research development about the entire thing of healthy lifestyle. Thank you very much, and I should thank a lot for giving your time to give such a wonderful talk to our students and other staff. Thank you, Ranjani.
Thank you, Dr. Dinesh. Thank you, everybody. I hope it was useful. Thank you.
Over to Angela.
Thank you, ma'am. Thank you, sir. Okay, a single act of kindness throws out roots in all directions, and the roots spring up and make new trees. On behalf of Sarvodaya Nursing Institution, I would like to express a token of gratitude. I would like to thank our resource person, Dr. Ranjani Harish, for sharing her valuable thoughts. It was really enlightening, ma'am. Next, I take this opportunity to express my sincere thanks to our chairman, Mr. V. Narayanaswamy, and our managing directors, Mr. Sunoj Matthew and Mr. George Thomas, for their continued support and encouragement. A special thanks to our principal, Dr. Dinesh Selvam, for inspiring us to do our best. Next, I would like to extend a sense of gratitude to all our beloved Vice Principal, Professor Jolly Joseph, for her dedication and support. A hearty thanks to Associate Professor Ramya, Nursing Program Coordinator, for a valuable contribution. With deep sense of appreciation, I thank our loving faculty members for their untiring effort. I also want to thank Mr. Bibin Babu, who worked behind the scenes to execute this event wonderfully. Last but not the least, I would like to thank the participants and the students of Sarvodaya Institution for making this event a successful one. A big thank you to one and all for joining us today, and the e-certificates will be emailed to the registered participants. You can also watch this presentation on YouTube channel, on our YouTube channel, Sarvodaya College of Nursing, and don't forget to subscribe to our channel. Until we meet again for the next webinar, thank you one and all.